I want to thank Amir and Ted for inviting me again, and Joe for me being able to harass him. This is a tough talk for me because, of course, as a surgeon, I don't feel like I ever do any marginal indication fixations. But yet, maybe some of the things that do. So I see Steve over there, that's good. But the idea being is that what I thought we'd do is go over some of the indications I have for surgery and then show you a case from a friend of mine. I'm not going to mention his name, but everybody would know his name. You may be able to figure it out. So this is the oldest pelvis amalgam I've seen. This was in Rome 3,000 years ago. Probably that's why he died. But there are some things that are obvious. That is unstable. That's unstable. And so we don't have too much argument in some of them, but I'm always surprised at how limited knowledge is about this. So a lot of it is unfortunately, my thoughts. This is a little more tough, but he just talked about it a little bit. But this is, you guys are wise. You knew that there was bilateral sacral fractures with those. And interestingly, I fix a lot of them in the wall. So this is the wall, 30 feet high, and when they fall down, they calve those. And I also found out why it's about 6 to 10 to 1, women versus men, because on their side they have a fence, and on our side they have a rope, and the women aren't strong enough to hold it, and they end up falling down and breaking their pelvis. This is typically how I fix them. I do the lumbo only for the reduction, and then I take it out, so I'm not quite as good as him at doing it on a shorter thing. So. And then get the reduction. So here's the case that I'm going to talk about, and it's probably hard to see, but there's a rami fracture on the left side of the patient, and a sacral fracture. And so this was what was done. To be honest, what I would have done is I would have probably done touchdown weight bearing on that left side for 8 weeks. This is done by, I said, my friend of mine. And of course, he came to me because he was having some hardware pain and some other things. And so I called and I said, "Why did you do that? That's crazy." And he said, his indications, they're too painful to mobilize. They do an exam under anesthesia with 5 to 8 pounds with manual compression. If there's instability, then they stabilize it. Now, there is some good literature that helps with the pain, but at 3 months, we can't say that there's any difference. This is an example of me doing something wrong. I fixed a malunion. I did something wrong. This is my bad case after it came from Borelli. But the idea is he had ischial non-pain. I fixed a malunion. I put some screws. The ischial pain went away. He started having problems in his SI joint. But it's the same kind of picture. There's a little bit of sitting imbalance. The ischium's higher. There's a little flexion of the pelvis. I would have elected to treat it conservatively initially. So this is a much bigger surgery. We had to stick a piece of graft, did a sacral osteotomy, had to fix the front and back. But it did take care of his pain because we reduced the pelvis. This is a windswept pelvis, and the initial fixation of it wasn't bad, except for the fact they didn't do the rotational. So there's no elevation of the pelvis there. And so when it was a she, when she first came to me, I took out the screws hoping it would get better, and it didn't get better. But now it's a much more difficult problem because they fixed a malunion to some degree. So I got to do a segmental taking out of the right side and close the right side down and then open the left side. And so this is actually her, and kind of reduced it, and then she did better. So these ligaments in the back are some of the strongest. And so my indication is for fixing them if they're unstable. And we talked a little bit about that, and I'll go over that. There's also some deformity, and that may be the marginal. I think this is an important slide to understand that each one of these axes has a rotational deformity as well as a rotational versus translation. For instance, that x-axis has a diastasis or impaction on translation and a flexion or extension on the x-axis. I think physical exam is important to make sure things are symmetrical, and generally your ASIS and your symphysis line up. This is Dr. Poleman doing a stress strain test, and you got to go, this is your homework, go home to your significant other and push on their pelvis, and you'll see it rocks together. When it's unstable, you can really feel the difference there. We know x-rays are important. Interestingly, I think the CT is more important for the pelvis than it is the acetabulum. That sounds weird, but it's hard to see those sacral fractures. And whether there's an impaction or if there's just a non-displaced fracture, you can also look at a lot of other things with that. But those things are the most important. So here's my definition of instability. If there's 5 millimeters of a sacroiliac displacement, because those ligaments, there's not a lot of bony architecture. So if those ligaments are torn, I think those are unstable injuries. Now, it's a posterior fracture gap versus an impaction. If it's an impaction, I don't worry about it. Some of those avulsions you see, that doesn't mean it's unstable. It could be a sign of instability, but it doesn't mean so. So what are some of the indications? Certainly hemodynamic instability, open, neurologic depression or decrease. Lateral compression injuries often give you not necessarily instability, but may give you a deformity. And so generally if there's more than 1 centimeter of leg length or more than 15 degrees of internal rotation, I think that those people generally have problems. Sometimes with rami, it can be sticking into the bladder, the rectum, or the vaginal wall. My open book is a little higher than what you might hear people quote, 2.5 centimeters, but if there's a centimeter, again, because of that ligament instability, I tend to fix those. Generally unstable pelvic rings, how we defined it, and generally we don't fix ramis unless there's more than 1.5 centimeters. So this case I would normally have done, if there was just an anterior ring, I let them go weight bearing is tolerated, but if there's some kind of fracture in the back, I'll do touchdown weight bearing for a total of 8 weeks. We did a study on the fractures. This was a while ago. 84% of the unstable posterior pelvic injuries, we didn't fix the rami, and we didn't have any of those fail. So I think it's safe not to fix those, although I see a lot of screws. Just as an example, these things should heal. This one didn't. This is 5 years after all kinds of things done to her. And unfortunately, that's what we fix. So I don't usually plate the inferior ramus because you fix the one on top, it should be good enough. But given the time thing, we fixed both of them, and she was very good afterwards. In terms of A fractures, avulsions, most of those you probably don't need to fix. Certainly if there's more than a centimeter of displacement, you could fix them, but a lot of them you can treat separately. Or conservatively, sorry. Lateral compression injuries, it really depends on how much it is. And a lot of times they have an impaction in the sacrum, so you don't need to do it. If there's a certain amount of internal rotation, like more than 15 degrees, you might consider doing it. On the higher lateral compressions, if you start getting like a lateral compression 2, the iliac wing, I think those end up being unstable a little bit, and so you still by testing it, you can tell by physical exam, but those are ones that I tend to fix. And so here's some example of fixing. Sometimes you don't need iliosacral screws, just fixing the bone of the iliac wing is all you need because the SI joint is still good. Windswept pelvis, we showed a case of it already, but and this is her initially. What about those anterior rings? The posterior ring's fine, but there looks like there's maybe even more than 20 degrees of rotation, as in this case, or a centimeter. Here's an example of it, kind of a lateral compression injury, and really it looks pretty stable. On your CT, you still have a hinge there. So I felt like that was a stable injury, and simply doing an X-fix on that kind of corrected the internal rotation deformity, and the patient ended up fairly well, and we kind of went over that already. What about open book pelvises? Those are a little bit controversial. The AP1s have a little bit of opening. AP2, you end up getting some of the sacrotuberous, sacrospinous ligament. And then the 3s are complete disruptions. I think the difference with the AP3s is that a lot of people will put screws in the back. Do you need them? I don't think you do. So 8 centimeters opening. If you look at the CT scan, you'd say, sorry about those views. If you look at this view, you say, oh, it's definitely damaged. But where the last ligaments are, the inferior part of your iliosacral joint and on posteriorly. So if you go down further, that's together. So I think most of these end up getting iliosacral screws. I just did this in the front and said I was done. Now, and I still don't think it's a problem, but if you can't trust a priest, who can you trust? But this is a priest. He never kept his weight off of that right side. I told him to keep off touchdown for 8 weeks. Whether it mattered, I don't know. He came back at his first follow-up. He was open. He came back at a year. It's broken. He's not having any pain, so we didn't do anything about it. But again, that might be an argument for putting screws in the back. I don't think so. So in summary, I don't think I would do that. I do think percutaneous screws can work, especially in large people. We have the Louisiana Fat Boy, which pretty much takes everybody. But I think the key is getting the reduction, and this is fixing the opposite pelvis to the table so that we can use. Hopefully, we've evolved in percutaneous fixation, and hopefully it's not like Whitney Houston, before Bobby Brown. So in conclusion, just because you can doesn't mean you should. Experience is not doing a better job, it's doing a better job quicker, and the pelvis is a place to work, not a place to play. Thank you.